So just a housekeeping note for individuals who are claiming CME, continuing medical education credit for today. The paperwork for the CME credit today is a separate form than yesterday. If you don't have today's paperwork, please see John Harrington at the registration desk and he can get you the form. It's a separate one from yesterday. Yesterday doesn't count for today. So moving on in our attempts to carry on conversations, educate, and discuss issues related to symptom control, we're going to start with Janet Dean talking about spasticity. I've been at a lot of different medical centers around the country, between medical school and residency and beyond, and it's interesting. There are different institutional philosophies everywhere you go. That sounds kind of strange. Medicine should be the same whether you're at University of Texas Southwestern or Presbyterian or the Mayo Clinic or Johns Hopkins, but it's not true. There are definitely personality differences and there are ways that things are practiced. One of the hardest things about making the move from Baltimore to Dallas was giving up my addiction to a drug called the Kennedy Krieger Institute. The Kennedy Krieger Institute, and specifically the spinal cord rehabilitation team at the Kennedy Krieger Institute, I can honestly say is the absolute best at what they do. So when it comes to treating patients with nervous system disorders that affect the spinal cord, central nervous system, multiple sclerosis, transverse myelitis, neuromyelitis optica, ADEM, Janet and her team of nurses and doctors and physiatrists and therapists really are spectacular. And I think I've figured out why. The first reason is they are always trying to do better. I have yet to see them take whatever success they're having, which is quite significant, as good enough. They don't believe in good enough. And so they're constantly setting the bar higher. And the second is they are an incredibly passionate and enthusiastic group who really care about the patients they take care of. And there's really nothing that describes Janet better than that. She's been a wonderful clinician, an incredible advocate for her patients, and when it comes to managing issues like spasticity, she's one of the first people we turn to. So I think it's going to be a wonderful talk, hopefully give you guys some insight for something that affects a lot of us personally or our friends or family. So I'm going to turn the stage over to Janet.
Thanks. So I get the snooze spot, I guess, today. So I'll do my best to try and keep people awake. All right. So today I'm going to a few things I want to try and do is provide you with just a little bit of an overview of spasticity, explain why it's important, why it is and actually isn't important sometimes to manage spasticity. Describe some options for management of spasticity, and then to look at sort of patient criteria for selection. So first of all, I would just want to do a little anatomy and physiology to explain a little bit about spasticity. So spasticity is caused when there's an injury to the upper motor neuron. And that includes the brain and the spinal cord above lumbar level 1, so above the lower spinal cord. And spasticity occurs because we all have something called the spinal reflex arc, and it's all part of the fight or flight mechanism that we have. And in general, when you've had some injury to your brain or spinal cord, below the level of your injury, your spinal cord is still intact, and so this reflex arc is intact. And the way I like to explain it to patients is when your spinal cord, when you have an intact reflex arc and there's a good connection between your brain and spinal cord, if you were to do something like touch a hot fire or step on a nail, your body responds immediately and your hand jumps back from the stove and everything is done when you touch something hot. But when you've had a spinal cord injury or an injury to the upper motor neuron, if you touch a hot stove, your hand jumps back, but because there's not a good connection between the brain and the spinal cord, it keeps going. If your spinal cord isn't injured, your brain says, calm down, you're all right, there's no problem, you're done. But when you have an injury, that doesn't happen. So, Now I'm just going to talk about the official definition of spasticity. So generally, spasticity it's a velocity-dependent increase in muscle tone. So when your nurse practitioner or doctor is moving you around to assess spasticity, they're going to usually be moving your extremity rapidly to assess if you have spasticity. Also, people tend to have exaggerated tendon jerks. That's when they use a little hammer to hit your knee. Your reflexes will be brisk. And you have repetitive stretch reflexes, which is clonus, like if your foot gets on the edge of your wheelchair pedal, your foot may go back and forth without your voluntary control. So there's other terms associated with spasticity, and I know I'm guilty of this when I'm talking with patients, to go back and forth between talking about spasticity and talking about increased tone or muscle spasms, flexor extensor tone patterns, and they're all part of the same mechanism, and we sometimes use them interchangeably and maybe not correctly so. Contracture is another term that you'll hear, and that's usually something that you have if spasticity has been long-standing, where you're unable to move the joint because of the muscle changes. So spasticity is also part of what's called an upper motor neuron syndrome, and this includes deficits. Many people that have spasticity also have problems with sensation, perception, maybe cognition if brain was involved, and motor control. And other motor control issues besides spasticity also can include weakness, so you can't generate enough force, slowed movements, loss of fine motor control, and then loss of selective control. So there tends to be sometimes tone patterns or extensor spasticity or flexor spasticity, and the inability to kind of control that voluntarily. Another thing that you hear talked about probably maybe when people are assessing you is the Ashworth scale, and it's what is used to measure tone, and there's a few different permutations of this scale, but it's generally from a 1 to 5 or a 0 to 4, or some of them have a 1+ in there, where when you have no tone, you're either a 0 or a 1, and then there's different permutations. So if you just have a slight catch when they're moving you, or up to the limb being fixed in a rigid or flexed or extended position when tone is really severe. Take a drink here. So is spasticity all bad, or is all spasticity bad? Absolutely not. So there's lots of things that spasticity is helpful in. It can stimulate the periosteum or your bone. It can retard osteoporosis, decrease edema or swelling, like in your extremities when you don't have as good a circulation. Spasticity can actually help pump fluid and blood back to your heart, so it helps to lower the risk for blood clots. When your muscle is contracting, even involuntarily, it's building bulk, and it can also help to decrease the risk of skin breakdown, partly because it can help maintain muscle, but also because it may involuntarily make you shift your body position if you're always sitting in a wheelchair. It can help to not a lot of extent, but to some extent. And then, of course, for a lot of people, extensor tone or extensor spasms are really important because it helps with transfers and walking, and it can also help even in a seated position with upright tone and balance. So for some people, taking away spasticity would not be a good thing at all. So the next question is, so why do we want to manage spasticity? So first and foremost, the reason that we think about managing spasticity is to improve function. So if there are therapy goals that you're not able to reach because your spasticity is getting in the way, then certainly that's something that we're going to think about wanting to look at treating. So mobility, fine motor control, even improving positioning, and to improve range of motion if your spasticity is interfering with being able to do that. Also, spasticity can cause, if it's severe, can really drain energy for people and can cause fatigue. Other reasons is to improve comfort. So spasticity can be painful, so we would like to decrease pain, decrease spasms, if you need to wear orthotics, we can help to improve the wear and fit of orthotics. And another thing is sleep. Some people have bad spasms at night that are interfering with their sleep. And, you know, it's hard to function if you're not getting a good night's sleep. So that's another big reason we would look at treating spasticity. Ease of care. If activities of daily living, dressing, bathing, cathing are difficult to do, we would look at that. Improve hygiene. If you've got spasticity so you can't, you know, straighten your arms out, you can have trouble with skin breakdown and just not being able to clean in those areas. Concerns for safety. Some people can have such bad spasticity that they're throwing themselves out of their wheelchair, either forward or backward. They have trouble transferring because their legs buckle up underneath. And then most importantly in children, spasticity over a long term can cause a lot of problems that I'll talk about in just a second. And so for kids, we want to prevent deformity and prevent or delay sometimes surgery that might be necessary. So I work with children, and we tend to be quite a bit more aggressive in managing spasticity because the end results of spasticity is not good. Spasticity imposes abnormal forces on children's growing bones, and neither the bones nor the muscles grow normally when spasticity is involved. And it can torque on like the long bones in your legs and it contribute to bony deformities. And then it can torque on your spine and cause scoliosis. And it's directly related to how kids grow. So we're, with really young kids and adolescents, we're worried about their trunk because that's where their bodies are growing the fastest. And more school-age kids, they're growing in their legs. And so we're really worried about spasticity and management of tone in that area. So goals for children, as I said, prevent or delay surgery. Some areas that are, that spasticity isn't the whole reason that people have problems with hip dislocation or scoliosis, but it certainly contributes. So those are things that we're looking at preventing. And then soft tissue, tendon, and joint contractures. If you can't get your legs straightened out, you can kind of get so that stuck in positions that we don't really want. So, if we're going to manage spasticity, the treatment plan has to include several things. First, we need to look at the age and size of the individual that we're treating. That's going to make a difference. Certainly, the goals of the individual and their caregivers are going to be very important. Also, goals of your healthcare professionals, of things that we're trying to prevent from down the road. We're looking down the road and trying to keep you or your children healthy. So we certainly have goals. And then once we decide on a management plan, you make an intervention and then you need to reevaluate and then make changes based on the results of that. So I'm going to talk now a little bit about different management options. So the first thing I'll talk about is the management of medical issues that can exacerbate spasticity, some rehabilitation techniques, oral medications, localized injections, intrathecal baclofen therapy, and then surgery would be a last option, and I'm not going to talk about that at all because we don't want to have to go there if we can help it. So issues that exacerbate spasticity, I see a lot of kids that come to me or come on the inpatient program or come in the outpatient program that are having a lot of spasticity, and the first thing I want to know is, are there medical issues that are contributing to that, and make sure that we have a good handle on that. Infection is something most frequently is urinary tract infection, so sometimes people can have urinary tract infections and either know it or not know it at the time, and we don't automatically treat urinary tract infections or treat bacteriurias, as was talked about earlier, but sometimes people do have infections that would be worth treating. Constipation, I find, is a big issue. And so we often will do an x-ray of their abdomen to just see how full people are. And we'll then, if that is an issue, we'll help to take care of that. Skin breakdown, if you have a sore somewhere, that can be causing spasticity. Even simple things like braces being too tight and irritating, body jackets, if you have one, can cause increase in spasticity because it triggers that reflex arc because it's noxious stimulation. Ingrown toenails are another thing that we can see. And it may not cause huge increases, but it just sort of elevates the threshold, so other things really trigger off spasticity. So, treating spasticity, as Dr. Pardo said, treatment for TM is, rehabilitation, 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 and it's the same for spasticity. The program that I work in is very focused on activity-based therapy, and Dr. Becker's going to talk later today more specifically on that, but we use a lot of patterned activity, and that can be done with or without functional electrical stimulation, where you use electrodes and a machine to help stimulate muscle contractions, and functional electrical stimulation can be used to stimulate muscle contractions in the muscles that you want to be working, but it can also be used to fatigue, put on different kinds of levels to fatigue muscles that are overactive. So we can try and damp down those muscles that are spasming while we're working with the muscles that we want to work. So this is some of the equipment we use. The gal on the front is on a standard glider, so that allows you to pump with your arms and move your legs. It works really well for range of motion and just for some patterned activity and giving you exercise. The other picture is, as you know, the FES bike that is out in the lobby out here, and we use a lot of that, and I really see a remarkable difference in kids that are able to use the FES bicycle to really decrease amount of spasticity. It won't get rid of it all, but people's muscles are just much more fluid when I evaluate them. And this is another way to do functional electrical stimulation with that little gray box. It's called an MP unit, and it's got leads that go over to the electrodes that go on the skin. And like I say, we'll put, somebody's hamstrings are really firing, then we'll put, even in somebody that's partially ambulatory, we'll put some E-stim on the back to try and get those, hamstrings fatigued so that it helps with ambulation. Aquatic therapy. Aquatic therapy is wonderful for people with spasticity because generally, if you're doing it in a therapeutic setting, the water is warm, and that is really helpful for people with spasticity. So you can get in and really start moving around and exercising better in warm water. So we're really fortunate to have a really nice aquatic therapy program. But aquatic therapy programs are around in a lot of places, and even bathtubs and hot tubs at home, and if you go to the swimming pool that has a hot tub in the hotel lobby kind of thing, even that can be very helpful. So orthotics. Orthotics don't just maintain position, but actually when we talk about extensor or flexor spasms that people have, if you can calm down what's happening in the foot and the ankle, sometimes you can calm down that whole reflex. So we do tend to, if people have a lot of spasticity and are up on their toes or just having a lot of spasms, to use orthotics. And the same with the hands too. If you can keep the hands from going out, then you can sometimes stop more of the spasms. Other modalities, heat and cold, inhibitive casting or serial casting, we can use to put prolonged stretches on muscles, and that we can use in conjunction sometimes with Botox, and we'll talk about that a little later. And then proper positioning, just being comfortable in what you're sitting in can help to decrease spasticity, and it can prevent problems like skin breakdown that can lead to spasticity. So if we are having problems, I just wanted to mention that, particularly with children, problems during growth are really important. So we really monitor very closely with kids for spasticity and weakness and other things that add into bony deformities. And we periodically take x-rays of the spine and the hips, and then we refer to orthopedics for monitoring if we're thinking that some of this will need surgical intervention in the future. So now I'm going to talk about oral medications, and I'm going to talk about them first and just sort of get them out of the way, but they may not, particularly with children also, be a first line of intervention if we can get away without that, but they're often seen as a first line of intervention. So for oral medications, generally it's used for mild to moderate or generalized spasticity, so people that tend to have spasticity in a lot of areas. it is important to keep in mind that there's no oral medications that have any safety or efficacy studies done in children, although they are commonly used in children. But we do try and avoid if we can. Overall dosing guidelines, when you're looking at oral medications for spasticity, it's like low and slow. So we'll start out at a low dose, and we'll gradually increase the dose until we get the desired response or intolerable side effects. And if we get intolerable side effects, which most likely is drowsiness for pretty much all of the medicines except for one I'll talk to you about. If drowsiness occurs, sometimes you can get past that drowsiness if you just sort of hold at a dose for a little while. And your body will get used to the effects of the drowsiness, but it won't necessarily, it will still affect the spasticity. So you can try that. If side effects are intolerable, then for most of these medications, you really need to taper them down the way you went up because they will have some withdrawal symptoms. For kids, I usually try and keep medications out of school, so I'll do before school, after school, bedtime, because it's just a pain, especially when you're tapering up or tapering down, to have to be sending prescriptions to school. And then other things, there are extemporaneous preparations for there's an official recipe that the pharmacist can use to make a solution when there isn't a manufactured solution. But I have found that the medicine doesn't stay mixed very well, and I've had kids sort of going up and down between toxic and, withdrawal and not having effect with those solutions. So I'd rather crush up the pill and put it in a little bit of food or juice or something. So there are 4 medicines, and there may be a couple more, but the 4 most common medicines that we use for spasticity are FDA approved for spasticity in adults. And that's Baclofen, Tizanidine, Diazepam, and Dantrolene. There are other medications, clonidine and cyproheptadine are other ones, and then cannabinoids are the active ingredient in marijuana, and there's controversy about whether that helps with spasticity, but I think it is in more common use because there's more states that have medical marijuana legalized, so that's something that some people have tried. So Baclofen, oral Baclofen is probably the most common medication that you see used with spasticity. There has been some indications that Baclofen might inhibit neurorecovery, and so there are people that don't like to use it to treat spasticity, and certainly try to avoid it in the early stages. But I will say that none of the other medications have had any research to know whether they inhibit recovery or not. So just because we don't use Baclofen doesn't mean the other ones don't inhibit recovery. So you have to sort of take that, for what it's worth. Adverse reactions for oral Baclofen are drowsiness, fatigue, sedation, low blood pressure, constipation, nausea, anorexia, and respiratory depression. If you take too much, you can actually overdose on it. Some cautions that you need to know is you can't stop it abruptly. You have to taper oral Baclofen if you're on it, because otherwise you get severe exacerbation of spasticity, depending on the dose that you're taking. And it can be up to hallucination, seizure, and when we talk about intrathecal Baclofen, there's even been death from withdrawal. I'm not going to go into detail, but there's the doses for that, dosage forms. Tizanidine Hydrochloride, or Zanaflex, is one of the newer medications and is tending to be used more because of the concerns about whether Baclofen interferes with recovery early on. It also, all these medicines except for the last one, Dantrolene, our central nervous system, act on the central nervous system in a little bit different ways. The thing about Zanaflex is it's a much shorter acting drug. It really peaks in about 4 hours. So it is a nice drug if you have most of your spasticity is at night, and you can take Zanaflex and it will help you get to sleep, but it won't give you kind of a hangover in the morning. So that it can be used for that. I think the Tizanidine, my experience has been it's way sedating. It was billed as not being as sedating as Baclofen, but it's not been my experience that it is less sedating. Dry mouth, somnolence, asthenia, and dizziness are side effects, and pretty much the same as other medications. Cautions with these is that the medicine comes in tablets or capsules, and it's the same medicine, but it has a little different profile as to how it works, and they're not interchangeable. And you and your doctor can pick and choose one or the other, but just make sure that you stick with one, and that when you go to the pharmacy, if they give you capsules when you had pills, they'll tell you, oh, it's the same, don't worry about it, it's not. Liver failure is reported in the use with this, and so this is one of the reasons I tend not to use it very much in kids, because you have to draw blood, and kids just, it's not a good thing to have to do. Oral contraceptives will result in a 50% decrease in clearance, so you need less Tizanidine if you're on birth control pills. And then FDA warning is that there's a dangerous interactions with other drugs that are CYP1A2 inhibitors, and they potentiate each other, so you can get toxic on your regular dose of Zanaflex. And the important thing is, two of those medicines, ciprofloxacin or Cipro, and levofloxacin or Levaquin, are frequently prescribed for urinary tract infections. So we always check if somebody's having a urinary tract infection to make sure they're not, when we're looking at what to treat, that they're not on Zanaflex. So you have to be really careful with that. And that it's severe low blood pressure and severe sedation. So again, there's the dosage forms. Diazepam or Valium, the mechanism of action is, again, central nervous system. And this one really depresses all parts of the central nervous system. It is pretty effective for spasticity, but it is also kind of highly habit-forming. And it's used mostly as an anxiolytic. It does have, besides sedation, it also has problems with impairing memory, blurred vision, and decreased respiratory rate and heart rate. So you need to monitor heart rate. There's also alcohol is a problem with it. Grapefruit juice doesn't work well with it. It's not covered by Medicare and Medicaid for the most part. So I've had patients that had insurance and then wound up in a nursing home and wound up cold turkey off of Valium for spasticity, even with a spinal cord injury, and it's ugly when that happens. It also has some street value. People know what it is, and so anybody that has attendant care, sometimes I've had patients with their attendants are stealing their Valium, and so I try and stay away from that, like in teenagers, young adults. And then if you have any ADEM with cognitive issues, and like in traumatic spinal cord injury, we try, if there's a dual diagnosis with traumatic brain injury or cognitive issues, we really don't want to use Valium at all. And withdrawal symptoms, if you're going to taper off of Valium, you have to do it really, really slowly, because it takes a long time to get out of your system, and people get really jittery and anxious and just, I just can't stand it. So you want to be careful of that. All right, Dantrolene. So Dantrolene is medication, works differently. It actually works at the muscle level. It doesn't generally have any effect on the central nervous system, and it's approved for use in spinal cord injury, MS, stroke, and cerebral palsy, and so it's one that gets used fairly frequently. Again, the big problem with Dantrolene is that there is some hepatotoxicity, so there can be some liver issues, so we have to do blood draws with this one also. It may have some mild sedation, some weakness or fatigue, paresthesias, diarrhea, nausea, vomiting, but I haven't really seen people have too much trouble with it. And often it doesn't seem to be as effective as some of the other medications, but it's always worth a try. So again, have to draw blood. It's difficult to dose in children because the smallest capsule is 25 milligrams, so you can't break or cut the capsule and divvy up the medicine, and the dose starts really low. I did see that there now is an extemporaneous preparation, but it only lasts about a week in the refrigerator, so you'd have to be running back to the pharmacy a lot. So for oral medications, the upsides of oral medications are basically these drugs have been around, except for Tizanidine, they've all been around for a long time, so they're relatively inexpensive. They're pretty easy to administer, and it relaxes all your muscles. So the downside is that they don't generally work all that well if you have, fairly severe spasticity. They have a systemic effect, so they go all through your system. They cause sedation. A downside can be that they relax all your muscles, so you can, have trouble with scoliosis and things like that. Blood draws for monitoring, and then some have withdrawal symptoms. Okay, so now we're going to talk about local injections. And the most common one that you hear about is botulinum toxin. And that is used very frequently. Phenol is another medication. It can only be used in limited muscle areas, and I'm not going to really talk about that today. The thing about local injections is that they're temporary and reversible. We use them to treat problem areas generally. So if you have tight hamstrings, or if you have tight plantar flexors so that you're up on your tippy toes, then we'll use Botox. If your biceps are too strong and you're trying to be able to extend your arm, we'll use in those areas. So patient selection is focal spasticity that interferes with function. It's a good intervention for kids that are pretty little for other interventions, such as a baclofen pump, or that we try and avoid medications in. And we can use it to prevent or delay surgery. So, we make sure that we're getting the muscles that are causing their hips to pop out of the sockets. So Botox is injected into the overactive muscle, and it prevents the release of acetylcholine from the presynaptic terminals. And basically, it pulls the nerve away from the muscle, so the nerve can't tell the muscle to activate. And it blocks the signals at the neuromuscular junction. So there are two kinds of Botox, botulinum toxin A and botulinum toxin B. One's called Botox and one's called Myoblock. And there are other botulinum toxin strains too. They haven't been until recently approved, particularly for spasticity related to spinal cord injury or TM. And they were mostly used for facial spasms and spasms of the eyelid. But recently, Botox has been approved for spasticity in flexor muscles at the elbows, wrist, and fingers for 18 years of age or older. And as you can see, there is no approval for Botox in children under the age of 12 for anything. But Botox has been used for years and years and years in children with very little problems. So the onset for Botox, when we give you the injections, it takes about 24 to 72 hours to see any change in spasticity. The maximum peak effect is in about 2 weeks, 3 weeks after the injections. And it will reverse itself in about 4 to 6 months. And that's because those little neurites grow new sprouts, so they grow new little junctions, because your nervous system is pretty smart, so it just grows new connections, and so basically the connections are back. And then the good thing is there's little systemic absorption. When they give the injections, they basically say it doesn't spread much farther than the size of a quarter. So adverse reactions are mild pain at the site, maybe for 24 hours if you are fortunate enough to be able to feel. Little spread beyond the injected area, and the effects, if you have adverse effects, it's usually based on the dose. So if it's, this is like there's the art and the science of medicine, so Botox is kind of a little bit of an art of how much you give, and if you get a little bit too much in there, you might be a little bit weaker to begin with than you wanted to be, but you just have to realize that it will reverse over time. So we're really cautious at how we use it in people that are ambulatory or things like that. The cautions for that, they need to be separated by at least 3 months, and this is to prevent allergic reaction. They're worried that people might develop an allergic reaction to Botox. It does tend to lose effectiveness over time in repeated injections. We see sometimes that you do it once or twice and it works really great, but then it doesn't work as well after that. And the thing to keep in mind is Botox and Myoblock have different dosing, and your care provider will know that. They work the same, they just have different dosing. And then more recently, there's been a lot of kind of controversy with Botox in that there were some children that had very severe disease, that already had problems with swallowing and speaking and breathing, that got Botox injections and then had bad outcomes where they stopped breathing and even death has been reported. It's really not very clear that it was directly related to the Botox, but it was probably because doses were being used in higher than what's usually used. But there's been, millions and millions and millions of doses of Botox used, and I think there's like 6 cases or something that have come up. So it's really a very safe intervention. The dosing is done in units per kilogram, and each muscle, there's guidelines for how much of the medicine you put in each muscle that your provider will use. And so while it's a great intervention for little kids, you have to dose it based on kilograms and how much goes in that muscle. So with little kids, you have to be pretty selective. So you're working with your therapist to say, okay, what's the priority for this round? So we're gonna, they're up on their tippy toes to walk, so we're gonna do their gastroc so we can try and get them down. And it's generally developmentally driven. What are we trying to work on with children? So for Botox, the upside is it's reversible, it's focal, there's relatively no side effects, and it really is the best treatment available or only treatment for really young children. The downside is that it's reversible, that it goes away. It's very expensive. It can be painful if you have sensation, and it's limited by the weight of the child. So the last thing I want to talk about is Intrathecal Baclofen, and this therapy has been out, I think, probably going on 20 years now. And it can be used in anybody from basically the youngest kids. They say about 3 years of age and 30 pounds, but it sort of has to do with how much room you have to be able to put that pump in. And the pumps have gotten a little bit smaller and thinner over the years. It can be used with mild, moderate, or severe spasticity, but it's more commonly used in the moderate to severe spasticity. You need to have attainable goals. You have to have a family or an individual that's very committed to this program, because you're going to have surgery and you're going to have to come back for refills. And then you have to show response to a trial dose. So if it's called a screening trial, where they use a lumbar puncture to actually inject a bolus of the medication into the intrathecal space, which is the fluid that surrounds your spinal cord, and see if the baclofen actually causes relaxation of your muscles. And if we know that it causes relaxation, then we can be pretty assured that when we put the pump in, that you'll have a good response from that. So the mechanism of action is the same as for oral baclofen, except that we are delivering it by a catheter into the fluid that goes around your spinal cord, right where that spasticity is occurring. So literally the dose is microgram by microgram. And even my boss, who doesn't like baclofen, we use baclofen pumps because we can use it at the problem with regeneration is dose dependent. And so if we do it intrathecally, it's at microgram doses, right where it needs to go, and not having circulated all through. So we do use it. And again, if we don't have any other way to reach functional goals, and it's important. So the catheter is inserted into the spine, into the intrathecal space. So it's inserted down low and then floated up in the intrathecal space to the level that we want it, depending on whether you have spasticity in your upper and lower extremities. And then the catheter is tunneled around to your abdomen, and the pump is implanted basically just under the skin in your abdomen. So it's not like a C-section where we're cutting through muscle or anything like that. It's implanted in a pocket under the skin. So it's relatively non-invasive as far as surgery goes. These are the uses that we have it for, and there's really kind of 2 groups. Some groups of patients that we're just looking at improving the ease of care, that have severe spasticity, and then there's other groups that we're looking at improving function, and we really can see a lot of improvement. Complications from intrathecal baclofen include overdose, and that's really done. The only time you really see an overdose with intrathecal baclofen would be like a controller error, like me making an error in dosing, because the pump never fails going too fast. If there's very infrequent pump failure, but it would always fail going too slow. There's the catheter problems are the biggest problem, so you have to put this catheter in and tunnel it up. So you can have problems with the catheter coming disconnected from the pump, sliding back out of the interthecal space, or even breaking. So those are things, they've worked and worked and worked on the catheter, so it's less problematic than it has been in the past. And then lastly is infection, and that you only see right at the time of implant, around the time of the implant, that you can get a pump pocket infection, and should that occur, then the whole system has to come back out again. But I will tell you, in my experience with, I've had a lot of experience with baclofen pumps, and if that pump goes in and it's effective, and it comes out because of a pump pocket infection, 99% of the people are like, when can we put it in? When can we put it in? When can we put it in? Can we put it back in? So most people find it to be very effective therapy, even in the face of complications. So adverse reactions are overdose, includes just severe muscle weakness, somnolence, nausea, vomiting, dizziness, and then respiratory distress or even respiratory arrest if there's a large overdose. Other cautions, withdrawal symptoms. So intrathecal baclofen or oral baclofen your body gets adjusted to it, and you cannot stop it abruptly, and especially with intrathecal baclofen, if your catheter breaks or comes out, baclofen gets stopped abruptly. And so sometimes, depending on how high the dose is, you might have to be even admitted to the hospital to manage the withdrawal symptoms until the catheter can be replaced. The number 1, 2, and 3 signs of baclofen, intrathecal baclofen withdrawal are itching, itching, and itching. Tachycardia, you're going to have just really severe jerking muscle spasms and increased tone. And you can have even hallucinations and seizures, and there has been reports of death from intrathecal baclofen withdrawal. So it's a therapy that has to be, everybody has to be on the ball when you use this therapy. So dosage forms, 500 microgram per milliliter, 2,000 microgram per milliliter. Generally, the pumps are 20 ml pumps and 40 ml pumps now. They're twice as big as they were when they started out. So often we can get away with, every 3 to 6 months. I have many patients that have to the baclofen is stable for 6 months, and that's when we change it. So it's been great to have bigger pumps. So, I was going to go back. So the pump right there, so that's the pump. It's about the size of a hockey puck or a tuna can. And the thing right in the middle is the port where you inject the medication. And so this would be implanted under your skin. So to do a refill, you actually have to put a needle through the skin into the port and withdraw the medicine, put the new medicine in. It's just through the skin, so it's really not very painful. And if you do have sensation, we use Freezy spray or Emla cream or something like that on it. So the refills are not really terribly traumatic. And then you can see the catheter that's attached to the pump. And then to adjust the dose, that's all done by this thing called the controller here. And you can literally adjust the dose microgram by microgram to fine-tune the correct dose. And it's calculated in micrograms per 24 hours. And you can literally titrate it microgram by microgram. So it really works. It can be very effective, even in patients. I have some patients that are needed the pump so that they could be independent in their own activities of daily living. I had a young man who was quadriplegic, and he was having such bad extensor spasms that he couldn't cath himself, and he wasn't safe for bowel programs and all that stuff. And so we put a pump in him real early after he had a traumatic spinal cord injury. And he was able now to do all of his own activities of daily living and take care of himself, but he's still ambulatory with braces. And so we have it titrated, so he's got just enough tone to be able to walk with his braces, but we got it down enough so that he can do his activities of daily living. And it took a little bit of doing, but we were able to do that. So intrathecal baclofen, the upsides are, we don't want to think about it as a reversible therapy, but it really is a reversible therapy. If it doesn't work, the pump can come out. And while it is a surgical procedure, you know, if we have to do surgery on your hips because of hip dislocation, that's a way bigger and way more painful surgery than putting in the baclofen pump. And as I said, the dosing is very adjustable. Complications, you know, I told you the complications. Sometimes we've seen that if we really put the catheter in and put it up high, we can weaken people's trunk muscles and will exacerbate scoliosis. We don't create scoliosis in somebody that wasn't going to get it, but it may come on faster than it would have. The downside is you're tied to the medical system. You have to come back every three to 6 months to get refills, and then the withdrawal symptoms are pretty severe. So, in conclusion, I hope I did what I said I was going to do at the beginning, and I'd be happy to take any questions.